This video begins with a brief overview of health history taking, followed by the anatomy of the musculoskeletal system and the examination of each major joint, including inspection, palpation, range of motion tests, and maneuvers of the temporomandibular joint and neck, shoulders, elbows, wrists and hands, spine, hips, knees, ankles, and feet. We conclude the video with tips on describing your findings. In this video, you will see the examiner assess a healthy patient. In clinical practice, you may detect the same normal findings, or you may discover normal variations or abnormal findings. The extent of the musculoskeletal examination depends on the patient's condition and symptoms. As you examine the patient, ask him to report any tenderness and be alert to facial signs of distress. The health history interview is a conversation with a threefold purpose: to establish a trusting and supportive relationship, to gather information, and to offer information. In the case of new patients, you will gather information that will form the basis for a comprehensive written health history. For patients seeking care for a specific complaint, you may prepare a more focused, problem-oriented history. In either case, you will record the patient's chief complaint, along with common or concerning symptoms. Common or concerning symptoms relating to the musculoskeletal system include neck pain, low back pain, monoarticular or polyarticular joint pain, inflammatory or infectious joint pain with systemic features such as fever, chills, rash, anorexia, weight loss and weakness, and joint pain associated with symptoms from other organ systems. By eliciting the patient's concerns before the examination, you prepare for an examination that is efficient and productive. Before examining the head and neck, let's review their anatomy. In the head, the temporomandibular joint, or TMJ, forms the articulation between the mandible and the skull. In the neck, joints between the 7 cervical vertebrae allow a wide range of motion.
First, we'll begin by examining your head and neck, and we'll start with the jaw.
Begin the examination by assessing the temporomandibular joint. Place the tips of your fingers in front of the tragus of each ear. Then ask the patient to open and close his mouth.
Open, please.
Observe the motion of the jaw. Feel for swelling, and note any tenderness or crepitus.
Now we're going to do your neck, and I'm going to ask you to lower your gown, and I think we'll just do it to waist level.
Okay.
Next, inspect the neck, including the sternomastoid muscles, for symmetry, deformities, swelling, or abnormal posture. Then, palpate the spinous processes of the cervical spine, as well as the trapezius muscles and the muscles between the scapulae. Identify any areas of tenderness. Now test range of motion of the cervical spine. To test flexion, have the patient touch his chin to his chest.
Tip your chin to your chest, and just back to where you were. Again. Very good. Now tilt your head back.
To assess for extension, ask the patient to tilt his head back. Note any limitations in range of motion.
I'd like you to turn your chin to your right shoulder.
To check rotation, have him turn his chin to his right shoulder and then to his left shoulder.
Okay, now I'd like you to tilt your
For
head
lateral
to your right
bending,
shoulder.
ask him to bend his head toward his right shoulder
Good. then
and
left.
toward his left shoulder. Assessment of the shoulders requires awareness of important landmarks and articulations. The manubrium articulates with the clavicle at the sternoclavicular joint, while the clavicle articulates with the scapula at the acromioclavicular joint. Now note the three landmarks of the shoulder: the acromion, just lateral to the acromioclavicular joint, the greater tubercle of the humerus, and the coracoid process of the scapula. Medial and inferior to the acromion is the bony prominence of the coracoid process. Lateral and inferior to the acromioclavicular joint lies the greater tubercle of the humerus. The long head of the biceps tendon may be palpable against the proximal humerus. The subacromial bursa lies above, lateral, and anterior to the head of the humerus, deep to the deltoid muscle. When inflamed, this bursa can become tender. Begin by inspecting the clavicles, anterior and posterior shoulders, and scapulae for symmetry, noting any atrophy, swelling, or deformity.
Now I'm going to check your sternoclavicular joint.
Palpate for tenderness at the sternoclavicular joint, the acromioclavicular joint,
Up to your acromioclavicular joint.
and the subacromial area.
Any tenderness there? And here, same. Sternoclavicular, I'm following the clavicle out. Any tenderness right there?
No.
Okay, and out in here. Now I'd like you to raise your arms above your head, straight up, and bring
To evaluate the
them down
range
your
of
sides and
motion
all
of the
way down.
shoulders, assess flexion and extension by asking the patient to raise both arms to a vertical position.
All the way down.
Then extend them forward in an arc until past the hips.
Now I'd like you to put your hands
Assess external rotation by having the patient place his hands behind his neck with his elbows out to the sides.
again. Very good. Okay, now I'd like you to place your hands behind the small of your back.
Check internal rotation by having him place his hands behind the small of his back. If you suspect a problem, cup your hand over the patient's shoulders and feel for crepitus as the patient repeats the movements.
Okay, all the way down. All the way back. Good. Okay. Now we'll repeat on the other side.
Examination of the shoulders often requires selective evaluation of several additional structures. Begin with the acromioclavicular joint. Palpate and compare both joints for swelling or tenderness. Adduct the patient's arm across the chest and assess for tenderness. This is sometimes called the crossover test. Next, examine the subacromial and subdeltoid bursae. Passively extend the shoulder by lifting the elbow posteriorly. This rotates the bursae anterior to the acromion and facilitates palpation. Repeat on the other side. Then, palpate carefully over both bursae.
Put your arms at your
To examine the patient's rotator cuff, begin with the patient's arm hanging at the side. Palpate the sits muscles that insert on the greater tuberosity of the humerus. The three palpable sits muscles are the supraspinatus, located directly under the acromion, the infraspinatus, posterior to the supraspinatus, and the teres minor, posterior and inferior to the supraspinatus. Next, passively extend the shoulder by lifting the elbow posteriorly. This maneuver also moves the rotator cuff out from under the acromion. Then palpate the rounded sits muscle insertions near the greater tuberosity of the humerus. Repeat on the other side. Tenderness over these sits muscle insertions and difficulty holding the arms at shoulder level, known as the drop arm sign, are seen in sprains, tears, and tendon rupture of the rotator cuff. Check the drop arm sign by asking the patient to fully abduct the arm to shoulder level, that is to 90 degrees, and then to lower it slowly. Finally, check for bicipital tendinitis, or tenderness of the bicipital groove along the anterior aspect of the humerus. Rolling the tendon under fingertips may be helpful.
Any tenderness there?
No.
Very good.
Before examining the elbows, let's review their basic structures. Here is a posterior view of the left elbow. Assessment of the elbow joint includes examination of the ulna, its olecranon process, the overlying olecranon bursa, and the medial epicondyle of the humerus, seen also in this anterior view, along with the lateral epicondyle of the humerus. When swollen, the olecranon bursa may become palpable over the olecranon process. The sensitive ulnar nerve lies between the olecranon process and the medial epicondyle. Support the patient's forearm so that the elbow is flexed to about 70 degrees. Inspect and palpate the elbow, including the extensor surface of the ulna and the olecranon process. Note any nodules, swelling, or tenderness. Palpate the groove between the lateral epicondyle and the olecranon, and assess any tenderness, swelling, or thickening. Press on the lateral and medial epicondyles for tenderness. Avoid pressing on the sensitive ulnar nerve. As you inspect and palpate the other elbow, compare your findings. Next, assess the range of motion of the patient's elbows.
Bend your elbows. Bring your arms up. Good.
To test flexion and extension, have the patient bend and then straighten his elbows.
Very good.
To check supination and pronation, ask the patient to flex his elbows at 90 degrees and turn his palms up and then down.
And again. Very good.
Before examining the patient's wrists and hands, consider these important structures. Bones of the wrist and hand include the distal ulna and radius, the carpal bones, the metacarpals, and the phalanges. Related joints include the distal radioulnar, radiocarpal, intercarpal, metacarpal phalangeal, proximal interphalangeal, and distal interphalangeal. Inspect the patient's wrists and hands, noting any swelling, redness, nodules, deformities, or muscular atrophy. Next, palpate each wrist joint with your thumbs on the dorsum of the wrist and with your fingers beneath it. Then examine each metacarpal phalangeal joint. Place your thumbs just distal to the knuckle on each side of the extensor tendon. Your fingers should be on the head of the metacarpal in the palm. Squeeze the patient's hand between your thumb and fingers. Note any tenderness, swelling, or bogginess. Now palpate the medial and lateral aspects of each interphalangeal joint between your thumb and index finger, noting any swelling, bogginess, bony enlargement, or tenderness. Repeat on the other side.
Turn your palms up.
To check range of motion of the wrists and hands, ask the patient to flex his wrists and extend them, and move his hands laterally and medially. Then ask the patient to make a fist and extend and spread his fingers.
Open and close. Again.
The vertebral column, or spine, is the central supporting structure of the trunk and back. The vertebral column contains 24 vertebrae stacked on the sacrum and coccyx. The concave curves of the cervical and lumbar spine and the convex curves of the thoracic and sacrococcygeal spine help distribute upper body weight to the pelvis and lower extremities, while cushioning the concussive impact of walking or running. Anteriorly, the vertebral body supports weight-bearing. Posteriorly, the vertebral arch encloses the spinal cord. Muscles attach at the spinous process and at the two transverse processes. The vertebral foramen and intervertebral foramen together create a channel for the spinal nerve roots in the cervical vertebrae, while the transverse foramen forms a channel for the vertebral artery. The proximity of the spinal cord and spinal nerve roots to their bony vertebral casing and the intervertebral discs makes them especially vulnerable to disc herniation, impingement from degenerative changes in the vertebrae, and trauma. The spine has slightly movable cartilaginous joints between the vertebral bodies and between the articular facets. The intervertebral discs cushion movement between the vertebrae and allow the vertebral column to curve, flex, and bend. With the patient standing, inspect the profile of the spine, observing the normal cervical, thoracic, and lumbar curves. Also inspect the spine for lateral curvatures. There should be none. Next, palpate the spinous processes for tenderness and the paravertebral muscles for tenderness and spasm.
Now I'd like you to bend forward.
Next, ask the patient to bend forward and touch his toes. A lateral curvature from scoliosis may become more evident with this motion.
And just bend forward.
Watch as the patient bends forward again. The normally concave lumbar curve should flatten out. Now stand behind the patient and stabilize his pelvis with your hands. To assess lateral bending, have the patient bend to his right and left. To check extension, ask him to bend back toward you. To assess rotation, have him twist his shoulders to the right and to the left. These motions should be symmetrical and accomplished with ease. If the patient has low back pain, you will need to conduct a neurological examination of the lower extremities, including the straight leg raise to test for nerve root compression. To prepare for examination of the hips, let's review the pertinent anatomy. At the hip joint, the femur articulates with the acetabulum, a cup-like cavity in the pelvis. The hip joint lies deep to the inguinal ligament and lateral to the femoral pulse. Because of its overlying muscles and location deep in the pelvis, the hip joint is not readily palpable. On the anterior aspect of the hip, you can identify the iliac crest at the upper margin of the pelvis at the level of L4. From there, you can follow the downward anterior curve to locate the iliac tubercle, marking the widest point of the crest, and continue tracking downward to the anterior superior iliac spine. By placing your thumbs on the anterior superior iliac spine, you can move your fingers downward from the iliac tubercles to the greater trochanter of the femur. Then you can move your thumbs medially and obliquely to the pubic symphysis, which lies at the same level as the greater trochanter. On the posterior aspect of the hip, you can locate the posterior superior iliac spine directly underneath the visible dimples just above the buttocks. By placing your left thumb and index finger over the posterior superior iliac spine, you can locate the greater trochanter laterally with your fingers at the level of the gluteal fold. And from there, place your thumb medially on the ischial tuberosity. Note that an imaginary line between the posterior superior iliac spines crosses the spine at S2. The hips have three principal bursae: the iliopectineal or iliopsoas bursa, the trochanteric bursa, and the ischiogluteal bursa. When inflamed, these bursae may cause pain and tenderness in or near the hip or pelvis. The iliopectineal bursa and the ischiogluteal bursa are usually not palpable. If a hip is painful or limited in motion, have the patient lie on his non-painful side with the knee flexed on the affected side. Then palpate for tenderness over the trochanter, the sacroiliac joint, or the sciatic notch as appropriate. Now assess the mobility of the patient's hips.
Very good.
First, check flexion. With the patient supine, Place your hand under the patient's lumbar spine. Ask the patient to bend each knee in turn up to the chest and firmly against the abdomen. Note when the back touches your hand, indicating normal flattening of the lumbar lordosis. Further flexion must arise from the hip joint itself. As the thigh is held against the abdomen, observe the degree of flexion at the hip and knee. Normally, the anterior portion of the thigh can almost touch the chest wall. Note whether the opposite thigh remains fully extended, resting on the table.
I'm going to ask you to move over to the far edge of the table.
Next, check extension. Have the patient hyperextend the thigh in a posterior direction.
Far back with your legs straight as you can. Good. Back you go. Okay. One more time. Okay. Very good. Okay.
Check abduction next. Stabilize the pelvis by pressing down on the opposite anterior superior iliac spine with one hand. With the other hand, grasp the ankle and abduct the extended leg until you feel the iliac spine move. This movement marks the limit of hip abduction. Next, check adduction. With one hand on the patient's opposite hip, hold one ankle and move the leg medially across the body and over the opposite extremity. Next, test rotation. Flex the leg to 90 degrees at the knee. Then stabilize the thigh with one hand and grasp the ankle with the other. Now move the lower leg medially so that the femur rotates externally at the hip. Then move the lower leg laterally so that the femur rotates internally. Pain with these maneuvers suggests arthritis. Repeat each of these maneuvers on the opposite side. Accurate assessment of the knee requires an understanding of that joint's anatomy. Within the knee joint, the rounded distal end of the femur articulates with the flattened tibial plateau, and the patella slides against the femur and the trochlear groove. The knee joint is enclosed in a sac lined with synovial membrane. The suprapatellar pouch is an upward extension of this sac. On the upper surface of the tibia lie the medial meniscus and the lateral meniscus. The menisci cushion some of the stress on this weight-bearing joint. 4 ligaments help stabilize the knee: the medial and lateral collateral ligaments, and the anterior and posterior cruciate ligaments. With the patient supine on the examining table and with his knees in flexion, inspect the knees, noting their alignment and any deformities. Note loss of the normal hollows around the patella or atrophy of the quadriceps muscles. Then straighten the patient's leg and palpate the suprapatellar pouch on each side of the quadriceps, noting any thickening, swelling, or tenderness. Also palpate along each side of the patella. Identify any thickening, swelling, or increased warmth. Repeat on the other side. Next, as the patient tightens the quadriceps, check for a smooth, sliding motion as the patella moves distally in the trochlear groove. If the patient has a history of knee pain, compress the patella and, with the patient's leg extended, push it down against the underlying femur. Now, with the patient's knees flexed, palpate along the medial and lateral joint lines for degenerative changes or meniscal tenderness. Also, palpate along the medial and lateral collateral ligaments for tenderness. Later, when you check the ankles and feet with the patient standing, Observe for any swelling in the popliteal spaces behind the knee. None is seen here.
Bend your knee and bring your foot all the way in. Okay? And then
The principal movements of the knee are flexion, extension,
again.
and internal and external rotation. Ask the patient to flex and extend the knee. Knee flexion and extension can also be assessed by asking the patient to squat and stand up. Be sure to provide support as needed.
Ready? Very good. Okay. Now just back up and I'll help you back up. Okay?
Then check internal and external rotation.
And then in.
Instruct the patient to rotate the foot medially and laterally. A set of 4 maneuvers will assist you in testing each of the 4 ligaments of the knee. While you will perform each maneuver on both legs, we will demonstrate on one leg only. To test the medial collateral ligament, or MCL, perform the abduction stress test. With the patient supine and the patient's knee slightly flexed, move the thigh about 30 degrees laterally to the side of the examination table. Place one hand against the lateral knee to stabilize the femur, and the other hand around the medial ankle. Push medially against the knee and pull laterally at the ankle to open the knee joint on the medial side. To test the lateral collateral ligament, or LCL, perform the adduction stress test. With the patient's thigh and knee in the same position, change your position so you can place one hand against the medial surface of the knee and the other around the lateral ankle. Push laterally against the knee and pull medially at the ankle to open the knee joint on the lateral side. To test the anterior cruciate ligament, or ACL, check for the anterior drawer sign. Begin with the patient supine, with hips and knees flexed to 90 degrees and feet flat on the table. Cup your hands around the knee with the thumbs on the medial and lateral joint line, and with fingers posteriorly on the medial and lateral insertions of the hamstrings. Draw the tibia forward and observe if it slides forward like a drawer from under the femur. Compare the degree of forward movement with that of the opposite knee. No anterior drawer sign is seen here. To test the posterior cruciate ligament, or PCL, check for the posterior drawer sign. Keep your hands positioned as for the previous test. This time, however, push the tibia posteriorly and observe the degree of backward movement in the femur. No posterior drawer sign is seen here. Before examining the patient's ankles and feet, let's review the structures that are important to your assessment. The bones of the feet include the calcaneus, or heel bone, the talus, the metatarsals, and the phalanges. The Achilles tendon inserts on the calcaneus. The talus articulates with the fibula and tibia, forming the ankle joint. Other joints include the subtalar, transverse tarsal, and metatarsophalangeal joints. With the patient supine, inspect the patient's ankles and feet. Note any deformities, nodules, swelling, corns, or calluses. With your thumbs, palpate the anterior surface of each ankle joint, noting any bogginess, swelling, or tenderness. Feel along the Achilles tendon for nodules and tenderness.
Over here. Okay. There you go. Any pain?
Test for tenderness of the metatarsophalangeal joints by compressing the forefoot between your thumb and fingers.
Bring it over here.
Evaluate each of these joints by palpating the metatarsal head and the sole of the foot and compressing the joint between your thumb and finger. To assess the range of motion of the ankle, dorsiflex and plantarflex the foot at the ankle. Next, stabilize the ankle with one hand and grasp the heel with the other. Then invert the foot at the subtalar joint. Then evert it. For the tarsal joints, stabilize the heel and invert the forefoot at the transverse tarsal joint. Then evert the forefoot. Finally, flex the toes on the metatarsophalangeal joints. There should be no pain or limitation of movement. A clear, well-organized clinical record, employing language that is neutral, professional, and succinct, is one of the most important adjuncts to patient care. For a healthy patient, your write-up might include language such as good range of motion in all joints, no evidence of swelling or deformity. To summarize, examination of the musculoskeletal system includes inspection, palpation, range of motion tests and maneuvers of the temporomandibular joint and neck, shoulders, elbows, wrists and hands, spine, hips, knees, ankles, and feet.